Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for September 29th, 2022. Today's CME activity code is 486595. This is being recorded. We'll eventually get it up on YouTube. Anybody not on our email list, send one of us an email. We'll include you. Go to our YouTube channel. We have about 50 of these conferences posted up there. Please join the channel. It'll let you know when we post new ones. And any feedback is welcomed, and invite any of your friends or colleagues to join us. We have nothing to declare as usual, and also to ensure patient privacy. Most of their information, including age, gender, ethnicity, dates, exact laboratory values, have been changed to disguise their identity and to protect their confidentiality. We've got some guests today. It's interview day, so we'd like to welcome them, and glad to have them join us. We've got a really good case today. It's a fun one. Dr. Baxi has put together a nice case, which will, I think, stimulate a lot of discussion of a lot of somewhat controversial issues. As you will see, that there are very few mandates in nephrology about treating glomerulonephritis, or I should say renal disease in general. Praveer, it's your case. You want to walk us through it?
Yep, absolutely. So we have today, I share the file. So for those who can't see the screen, you should have a PDF version, but we have a 50-year-old Black woman who presented to us with for really worsening lower extremity edema through the emergency room. She had a history of hypertension and pulmonary embolism, and that was her main prior history, and we'll go into that. Of note, she was just admitted to a different hospital just 2 weeks prior to presenting to our hospital with severe anemia, and this was thought to be due to her uterine fibroids, and she had severe vaginal bleeding to the point where her hemoglobin was down to 5.5. She is on anticoagulation due to her history of PE, and her INR on that admission was noted to be 20. Her creatinine was 1.9. The last known one that we could find was from about a year ago, and that was 0.8. She had a urinalysis that was checked during this outside admission. Again, it was in the setting of her severe vaginal bleeding, but it did show large blood with 1+ dipstick protein. There was no quantification that was available. During this admission, she was given intravenous fluids and blood transfusions, and ultimately discharged with her PCP with plans for an outpatient hysterectomy. Her anticoagulation was changed to Lovenox to help prepare her a little easier for the surgery, and given that her INR was severely elevated. She followed up with her PCP after this admission, and she noticed worsening of her bilateral extremity swelling. She was started on aldactone, 25 milligrams twice a day, about a week before presenting to emergency room. And she again presented to our emergency room because the swelling was not improving and now she was having some shortness of breath. So when we asked her for a little more questions, she said her swelling actually began about 2 months ago and had slowly been worsening. She said, in addition to this severe bleeding episode that she had 2 weeks ago, she was admitted to a hospital and seen in urgent care twice in the last 2 months for pneumonia. She was treated on Augmentin and then Levaquin with the most recent course. She had been taking a leave intermittently for some time, let's say about a month or so, she said, for just generalized pains. She had noticed decreased amount of urine output over the past week before presenting to our emergency room. She was hypertensive, afebrile. Her labs now at our emergency room showed that her creatinine was 16.35, potassium of 6, bicarb of 11, hemoglobin of 8.2. A repeat urinalysis here showed a 2+ protein, large blood, greater than 200 RBCs, and 2 granular casts. Renal ultrasound imaging showed no hydronephrosis. She had a chest x-ray done because of her shortness of breath. She had some mild pulmonary vascular distension with some bilateral pleural effusions and a left lung opacity, which was read as a resolving infection given her reported history. We started a serological workup. She started an IV Lasix given her shortness of breath and fluid overload, but she continued to have worsening azotemia, and ultimately we had to initiate hemodialysis, after which we did recommend a biopsy. In terms of other information, as I mentioned, she had a history of pulmonary embolism. It was 7 years ago and again 5 years ago. So she was given lifelong anticoagulation. She never had a DVT. From what we could gather, this was thought to be potentially related to her oral contraceptives that she was on at the time of these DVTs. She had hypertension, which was only about 2-year history she reported, and of course the uterine fibroids. History of C-section, no other major surgeries. Social family history, really not significant. She had only family history we could find out was a history of hypertension, but no kidney disease. Medications, she was on Lovenox, she was on atenolol, chlorothalidone for her blood pressure, along with recently added aldactone. She was on Provera from her recent discharge with severe bleeding, and then she was taking the leave intermittently. Review systems, besides the swelling and shortness of breath and the recent vaginal bleeding, nothing else. Exam, I mentioned her blood pressure was 160/80. Her BMI was 30. She was afebrile, not tachycardic. She was actually satting 98% on room air. On exam, the biggest thing was just her 2+ edema, which was bilateral. She had no other rashes. She was uncomfortable, not in respiratory distress, no rash, no other really things to note on her exam. Labs, her creatinine was, as I mentioned, 16.35. Her other electrolytes, sodium 133, potassium 6, chloride 103, bicarb was 11. Her BUN was 95. Her total protein was 6.5. Albumin was 1.6. Her LFTs and bilirubin were normal. WBC was 9.9. With a differential shown below, shown right there. Hemoglobin was 8.2. Platelets were 370. Her INR was still 2.37, and her iron stat was 30%, and ferritin was 400. The serological workup that we had available at the time of the biopsy was ANA was negative, anti-double stranded DNA was negative. Her complements, those are normal for our lab. Her rheumatoid factor was not severely elevated. Her ANCA, SPEP, UPEP were all pending, which again can take a week sometimes at our hospital. Hep B, Hep C, and HIV were negative. Her UA had 2+ protein, again with a greater than 200 RBCs. She had 35 WCs. We were able to quantify her protein with a UPC ratio of 3.4, along with a corresponding UAC ratio of 0.89. No hydronephrosis on the ultrasound. Her kidney sizes were 11.2 and 10.8. And I mentioned already the chest x-ray. And ultimately, after a couple of sessions of dialysis, we were able to get our IR colleagues to do a kidney biopsy.
Great. Any questions for Dr. Baxi?
Do you have a cholesterol, Pravir?
No, I didn't have a cholesterol.
All right. I think we're going to start with a poll. There's a question in the chat. Any rashes?
No rashes. She looked really well for her labs, and that was part of the issue with her. She didn't believe that she was as sick as she was. Light chain assay, that was pending, unfortunately, at the time of the biopsy. Urine output, she was oliguric, so she was, I think, about 400 or 500 cc's milliliters in a day. That was with the IV Lasix, and no history of preeclampsia that we knew of.
And the EKG voltage was normal?
Yes.
Okay.
Chintab, yeah, she was still having some vaginal bleeding at the time, and much lower than, of course, not the severe that she had before. So again, her urinalyses were sometimes hard to interpret. No family history of kidney disease, only hypertension.
All right, let's do our poll here.
Yep.
So we've got several polls today. So as usual, we like to see what people think before we go too far into it. So what do you think the pathology will show here? One is acute interstitial nephritis with ATN. Number 2, anticoagulant-related nephropathy. She had an INR of 20 or something. Pauciimmune GN. Seems to be a lot going on here, maybe. Paraprotein-related renal disease. We have a lot of those hidden amongst there. Membranous nephropathy. She's had some pulmonary emboli, things like that.
And the INR 20 was thought to be because of the Levaquin that she was given that can interact with.
Dr. Kalra brings up the possibility of a non-dilated obstruction. I think the authority of that diagnosis in our section is Dr. Baxi, since he reported a case of it. But that's always a tough one because we rely upon, the gold standard of ultrasound is normal.
Fortunately,
go ahead.
she had prior CT imaging studies. She didn't have any type of retinoperitoneal
involvement.
lymphadenopathy or anything of, in the abdomen. She had prior CTs because of her uterine fibroids. So a couple more people hopefully can vote in.
So any respiratory problems is in the poll. Remember that she's all started with pneumonia here?
Mm-hmm. Mm-hmm. 2 courses of pneumonia, which she said it gotten better. She had a little bit of shortness of breath that happened more recently, but she said her cough had resolved.
And she's never coughed up any blood or anything like that, right?
No, not that we know
No.
of.
Yeah, okay.
All right.
43% answers. We have got the poll up here. It's 16% say AIN with ATN. I think that's a good guess. Who's granular Cas, a pretty big increase in creatinine. We've got 33% says anticoagulant related nephropathy. I always like that diagnosis because it's something didn't even exist when I was a fellow. Well, I'm dating myself. Post-immune GN is the highest at 33%. Interesting, with trace proteinuria or 1+ proteinuria or something. Yeah, 1+ proteinuria. Paraprotein-related renal disease is always a good guess here because we have a lot of those, and they always make great cases for discussion. And we got 2 membranous people that have that voted for that. So with that, let me ask Dr. Whittier to discuss the case for us.
Sure, thanks. Yeah, all of those are really pretty, there's almost an equal distribution there, between the differential that you put on the poll, and all of them are really, I think, pretty high up on the differential. We've got this Black woman with severe kidney injury and quite a bit of hematuria, but she also seems to have nephrotic syndrome at the same time, although that's kind of why I was asking about the cholesterol, because it seems that her lower extremity edema and her hypoalbuminemia are out of proportion to the amount of proteinuria that she has. But of course, she has acute renal failure, and so it may be that her urine PC ratio is not as accurate. So we've got somebody here who has really what, if we're going to believe the urine, which is hard to do in the setting of her uterine bleeding, but if we're going to believe that, we have to put her in the category of an RPGN. In that category, she's also got some pulmonary issues, fleeting pneumonias that have happened a couple times. I think that's always suspicious for somebody who's got an autoimmune pulmonary renal syndrome, whether it would be Goodpasture's or ANCA-vasculitis or even alveolar hemorrhage you could sometimes see with lupus, are all in the differential. And her serology doesn't suggest lupus as much. We don't have a GBM antibody, and the ANCA is pending. And our ANCA does take a while to come back, so I don't think that's necessarily gamesmanship, but I would probably put an ANCA-based post-immune glomerulonephritis with crescentic GN high up on the differential. Again, I don't see as much lower extremity edema with that, but it's possible that her edema, again, like I said, is just bad renal failure. I mean, if she's becoming oliguric and they've been giving her a lot of fluid and she's not responding to diuresis anymore, then she's going to start to get edema too. So I think that's number 1 on my differential. Could she also have, I'm going to dismiss paraprotein related lesion for now. There's nothing really that suggests it's in the case other than the fact that those are pending, and I wouldn't usually see as much hematuria with that. Membranous,
Bill,
for sure. Go ahead.
Bill, can I, if you look at our protein creatinine ratio or albumin creatinine ratio, there's a huge gap there.
Oh, got it. I did not notice that, and I should have. Let's see here.
Roger, you gave it away.
I'm giving it anyway. I'm not giving it anyway. I'm just telling him that, he doesn't see a reason. I see a reason to think about that.
Yeah, I think I saw that her albumin was so low and she had 2+ protein on the urine analysis, and you're right, but that is a discrepancy. But there is albuminuria there for sure, which makes which is consistent with some glomerular lesion. But of course, there's glomerular lesions and overflow proteinuria, and all types of urinalyses can exist when we have a paraprotein related lesion. This is more nephritic predominant in my mind, but again, I could be fooled by the fact that she's got uterine bleeding. When I think of someone who's this swollen and they have nephritic, we also think about post-infectious GN, where they can have that as well, but her complements are normal. That doesn't exclude it, but it's something I would consider too in this situation. I like the idea of membranous as well, just because membranous is the most common GN that presents with thromboembolism. She has this history of PE, which predates this all, and it's possible that she's had membranous for a while, and that might be her predisposition to PE, you know, that someone missed because we didn't have a urinalysis then. But I think all in all, it's most likely that this is an RPGN, and I still think that post-immune vasculitis would be my number one.
Steve, what do you think?
I like Bill's differential. I agree. I think of this as kind of a rapidly progressive GN. You got hypertension, edema, you know, active sediment. I mean, I don't know how much the fibroids or whatever vaginal bleeding might be throwing this off, but and I think the issue of anticoagulation related GN is kind of an interesting. You know, the one thing that came to my mind. I mean, Bill's really done a nice job discussing the case in general, but the thing that also came to my mind is patients with IgA nephropathy who are on anticoagulants have a higher likelihood oftentimes of getting this anticoagulation related GN and acute renal failure. So, you know, it'd be interesting if this lady has underlying IgA nephropathy, is on anticoagulation, and now has anticoagulation related GN, because the two can coexist. For whatever reason, I just ran across this not too long ago. People with IgA nephropathy seem to be somewhat more predisposed to that problem when they're on anticoagulation. I guess the other thing to bring up, and I didn't catch, was she still getting Levaquin, or is she off the Levaquin?
She was off. That was about a month ago.
I was going to say quinolone associated vasculitis is another possibility, but if she's been off of it for a month, I think it's less likely. I agree with Bill. I think, you know, the hard diagnosis here, the one that's probably most that I think fits fairly well would be a post-immune vasculitis, and then all the other things are in the differential. But I think that's got to be high up. And again, I just throw in the IgA nephropathy with anticoagulation related GN superimposed on that, causing the acute renal failure. I know I keep going on here, but that discrepancy in the albuminuria and in the proteinuria is an interesting one. I mean, was she oliguric at the time that was done?
Yes, yeah.
So I don't know, you know, again, we've talked about this before. In that setting, a lot of these urine studies aren't as beneficial or as helpful as we'd like to think they are.
Yeah, I think that's a good point, because in some ways, I look at this case as, you know, something bad's going on. She's got a lot of hematuria, but she also has another explanation for hematuria. She's very anemic, but she also has another explanation for her anemia, being her uterine bleeding for both of those. But her urine's pretty, you know, it's really unimpressive from a proteinuria standpoint. And you're talking about an RPGN, I would think there'd be something more going on. But then we would say, well, you got to throw that out because of the AKI. But I want to believe it for this, but I don't want to believe it for that. It just seems like people have RPGN on their mind, and a little more than they should. That's my just personal opinion.
Well,
I don't know.
It's rapidly
I mean,
progressive. That's why it's RPGN.
Yeah,
well, it's what she has is AKI, Steve. I mean, what she has, does she have a GN? I don't know that she has a GN, because I don't know how much we can rely on her hematuria and proteinuria. That's the point I'm trying to make, which you obviously didn't make that well.
You throw out what you want to throw out, and I'll throw out what I want to throw out.
Okay.
Yeah, I think this would be. I think you know, you got fleeting infiltrates on this chest X-ray, or this previous history of pneumonia. You got hematuria, you got proteinuria, you got bad AKI. This is someone that I would actually not wait for the biopsy, and I'm probably wrong, but I would actually treat empirically with IV Solu-Medrol while waiting for the biopsy. That RPGN so high in my differential.
Hey, Praveer, was she iron deficient?
No, she wasn't, surprisingly, but again, she had received all these transfusions just a couple weeks ago, and so that may have unfortunately.
Oh yeah, I'm sorry, it's right there. I apologize. Yeah, yeah, because iron deficiencies go to these subtle things. If someone's been bleeding in their lungs for a while, that's one of those things. But then she also could have had uterine bleeding for a while.
Yeah.
Yeah, I'm a little surprised at how adamant you guys are. But Mario, what do you want to throw out?
Well, I got hung up on the electrolytes and some other aspects of her laboratory studies. She has both a high GAP as well as a hyperchloremic metabolic disorder. And for the fellows, notice I didn't coin the term acidosis because we don't have a pH and a PCO2. So the high gap is most likely due to the advanced renal failure with retention of organic anions. But what about the hyperchloremic component? Could that be due to the aldosterone, or could that imply a tubular interstitial disease with an underlying RTA? Then along the same lines, I looked at the difference between total protein and albumin and suggest hyperglobulinemia. We are waiting the pertinent SPEP and protein studies, we'll see. Then she's got a positive rheumatoid factor. And that to me is a cheap way of diagnosing cryo, which could fit with the current picture. C4 is normal for what it means. That's what I have to add. I mean, I suspect there is both a glomerular as well as a tubular interstitial process here, and I will be concerned about the possibility of cryo.
Pravira, is that, what's our normal rheumatoid factor?
That's very, just barely above normal, so it's not
Okay.
very elevated. Our, the normal, actually, that gets flagged as more or less normal. The upper limit of normal in our lab is 29.
Okay. In case you just put it on the chat, as right as you said it. All right. Anybody else have any strong opinions on our differential here? Did anybody throw in the chat what they feel strongly it's anything? Somebody says smells like membranoproliferative GN. It's always a possibility. A lot of times we like to see low complements for an MPGN, but certainly not always.
And, you know, we didn't discuss ATN and AIN, which was high on the poll. And certainly if we're going to throw out the urine completely, then that starts to go up a lot higher. I mean, if we're completely ignoring the urine, we've got, you know, somebody who's really sick and had all these pneumonias and they've got AKI maybe due to just being so sick.
Well, they're granular cast. I'm glad we got back to that, because I don't want to, you know, anybody. What about minimal change from or non-steroidals? It would be hard to say. She's in such acute renal failure. It's hard to make anything out of what her albumin and everything else would be. And we see plenty of acute renal failure with minimal change disease. In the chat, we have a post-immune GN with lung and uterine involvement. So this is Occam to the Occam. Occam would be proud of you, because you're not only giving him one disease, but one disease for the uterine bleeding and the pulmonary, you know, lung or whatever, pulmonary renal syndrome, if you want to put it that way. And the other thing that was brought up is if this is membranous, you don't typically get acute renal failure with membranous, but the two situations that you could would be renal vein thrombosis if it were bilateral. She's had PE. The PE were a long time ago. I do this mostly for just educational to bring that up, but crescentic membranous can occur. People can have membranous, and it's kind of an insidious. You can have membranous for a while, and then if it becomes crescentic, you could have AKI. So I think that's a good point that was brought up. An antiphospholipid antibody syndrome, given the fact that she's had PEs in the past, and the assumption was that the clots were from related to oral contraceptive use, but but we don't really have. Pravir, do we know what her antiphospholipid antibody status is?
No, not this time. She had an outside hematology workup, which which we were told that these were likely due to that, and then she was committed to lifelong anticoagulation. I put in the chat, it wasn't a clear history, and I don't think there was a good understanding of what workup was done before.
Yeah, well, I think those are all really good points. It's obviously a pretty broad differential. It'd be pretty easy if she just showed up with a creatinine of 2 and no uterine bleeding and sound like a pulmonary renal syndrome or something, but I think there's a lot of confusing factors here, which means we do a biopsy, which means it's time for the wheel. For anybody new today, we have a wheel that decides who reads the biopsy, and it has the second year fellows on it and the faculty on it, and the fellows have a two times chance. Their name's on it twice and the faculty's on it once. So we'll see who the great wheel picks today. Dr. Whittier.
Ready.
All right, remove spotlight. I'm gonna share the screen.
2 weeks in a row we've had an attending. I might have to work on that wheel.
Yeah, did you take off those weights? Oops, I didn't know I was unmuted.
You need a little WD-40 like your chair.
Thought those weights were supposed to do the trick, especially towards chin tuck. Go ahead, click on the screen. Yep, I'll let you advance it on the bottom.
Okay, great. You guys can see my mouse there. Good. All right, here comes the path. Okay, so here we have a low power trichrome stain, and I'm focusing in usually on the amount of blue staining material, which is not that much in this core, but certainly the tubules are sort of spread apart here. So there seems to be some scarring there. It's not as much blue as I would really have expected. I don't know what you're going to estimate it at, David, maybe 20% scarring?
Yeah, yeah,
Okay.
yeah, that sounds about right.
Okay. I'll kind of comment at a higher power for the glomeruli, but also there's what appears to be a large blood vessel here. I know she has a history of hypertension, but I can't really comment on this power of anything that's too abnormal there. Yeah,
we'll see that on future images.
Okay. Wow. This is a high power H&E stain of a glomerulus, and you really can't even make out Bowman's capsule. So there's a lot of inflammatory tubular interstitial infiltrate here, and the glomerulus itself also has too much pink staining material here. Usually I would think about a fibrinoid necrosis in this kind of area. I think it's hard for me to clearly make out the architecture of where the Bowman's capsule is or was, but maybe we'll see it better on a different stain where we can, a PS or a Jones where we could see that a little bit better. But here I see this pink staining material, which I would be consistent with fibrinoid necrosis. And I think there's also too many cells over here too. It's hard for me to tell whether that's endocapillary or mesangial. I would probably lean on David for that one.
I would bet the Bowman's capsule just blew up there.
Yeah, we'll see that on some other
Okay.
stains.
I almost wonder if this is sort of a
apart.
Yeah, if this is sort of a crescent, but it's just hard for me to tell what's inside and what's out. So I was hesitant to use that term on this specific one. But a lot of inflammation in the glomerulus and outside.
Yep.
Oh yeah, I'm the one that's forwarding. Okay, yeah, here's another H&E stain with what appears to me to be a circumferential crescent. What's left of the glomerulus is really here in the center, and it's kind of shrunken down and squished, and this glomerulus is definitely on its way out. Again, can't really make out the architecture of Bowman's capsule. Also some denuded tubules here with some ATN, probably a granular cast there, and no, those aren't. I think they're proximal with the damage to them as opposed to being distal tubules. And here's probably another granular cast in this tubule there. So, but the main thing here is, wow, big circumferential crescent.
Yep.
Next slide. Now we have a PAS, so we can kind of see the outline of Bowman space that I was wanting to see earlier. Here we have a area of, I guess this could be considered scar. The architecture is really complicated, but mostly not normal is all I would kind of say. It's sort of distorted and destroyed, and you do sort of lose Bowman space here. So maybe like Roger was saying, this is, the cellularity that's kind of even leaking out into the interstitium.
That could be all
Yeah, I
crescent.
mean, this is a destructive necrotizing lesion with rupture of Bowman's capsule. I think
Okay.
that there's a lot of parietal epithelium there forming a crescent mixed with
Sure.
the inflammatory cells. And there's
Okay.
little left of the glomerular tuft.
This is the tuft. This is all that's
Yeah.
left of it here.
Yeah.
Okay. Yeah, bad crescentic disease. Here's a Jones. Wow, there's this is just shows you how destructive these crescents can be. There's just Bowman space stops. It just stops over here too. And normally we're seeing breaks, and here's a really nice example of a enlarged capillary with a break right in it. We have pieces of capillary wall out into the urinary space that are broken up, and you can see these cells are just exiting, and this inflammatory reaction of the crescent is really just coming down to destroy this entire glomerulus.
Yeah.
Here is an H&E, and this looks very well preserved. Maybe, I don't know, I will get a number at the end of how many were, but this does not have any evidence, and goes to the nature of the fact that a crescentic disease can be focal. And I think here maybe some red cells in a tubule, but what, maybe a high power, maybe that's just granular cast, I'm not sure.
That looks like a red cell cast. Yeah.
Okay. And then here's some granular cast too. So really, this glomerulus is interestingly spared when the rest of the tubular system around him is destroyed. And it may just be that this is kind of the only one left to get hit yet.
Yeah, one of the few.
Okay, so we go back to the lower power, and this, lower power, I'm usually looking at trichrome, but I think this is a PAS.
This is H&E.
H&E, okay. And so you can see here, there's a lot of red cells in these tubules here. This is probably medulla, although it's hard for me to tell, but I think kind of what you want me to look at here is this huge artery. And at this power, we might be looking for arteritis, but I don't know if I can see it there.
Oh, yeah. Well, so that's transmural necrosis of an interlobular artery.
It is, okay.
Yeah, part of the necrotizing arteritis. It's the wall is completely necrotic.
Okay.
And in fact, just below it, you have half of an arcuate-sized artery. Yeah, right there. That's arcuate-sized, separating the cortex from the medulla.
And this one is spared, and
Yes.
this is normal color, and then this one is the arteritis that you're talking about, which is
Yes.
a lot more pink than here. So that's a good example of the difference in pink, if anybody can see that. And up here looks to be also some sort of hemorrhagic, inflammatory reaction as well.
Yeah.
So David, since we rarely see arteritis like that, I mean, clearly it looks abnormal. Is that hemorrhage in the wall there? Is that what's going on?
No, it's fibrinoid necrosis.
It's okay. It's fibrinoid in the wall.
Yeah. We'll see on some of the other stains how the architecture of the wall is broken apart.
I think this is what he's talking about here. This is just, and then all the inflammation that's around it is coming to it because of the arteritis.
Yeah, so several interlobular sized arteries had necrotizing arteritis. So here, the one on the right, you can still see is intact. And then the one, it must have a tributary there on the left, but it's completely necrotic. And on some of the special stains, we'll see some of the architecture that was there of the artery.
And so here's the Jones, and yeah, I think David, you could, we don't do the arteries as much, but again, I can see that this doesn't look normal, that this would normally connect, and there's just again, massive inflammation.
Right, there's transmural damage to the vessel wall, and down like around 6 o'clock, you can have a little bit of some internal elastic lamina still there, but the rest of it is all necrotic and broken apart.
So I was going to ask the same thing. Roger kind of alluded to this in the chat. So you've got a medium-sized vessel as well as small vessel involvement. Right, David?
Yep.
Which is not something we're used to thinking about.
And here is, boy, I wonder if this is a glomerulus here. It's hard for me to kind of make out the architecture.
Yeah, kind of like a kind of
artery.
ischemic.
Yeah, and then here's the again, more arteritis.
Yeah. Necrosis
Probably
of the
just a
vessel
secondary
wall.
lymphocytic infiltrate there. I don't,
Yeah.
It's like there's a primary.
Yep.
Okay, good. This is a PAS, really sort of highlighting the tubules here. We see some sloughing and some ATN here. Let's see here. Yeah, just quite a bit of ATN, I think, is what you're trying to highlight here.
Yep.
Okay, the posse immune. Yeah, so when you have a crescentic GN, obviously the immunofluorescence really gives us the insight into what the cause is, whether it's linear or immune complex mediated or posse immune. And so this IgG chain shows that at least the IgG is negative. Let's see if there's any other IFs.
Yeah,
so I assume
everything,
all the IF is negative.
Everything negative.
And not enough tissue for EM, or
Not a viable glomerulus there. Yeah.
okay, so my diagnosis would be a posse immune necrotizing glomerulonephritis and a medium-sized arteritis,
Yep.
along with some ATN.
Yep.
So it's a shame you didn't get some uterus with the biopsy, because I mean I didn't really think that strongly when about when I was hailing Occam earlier, but it's seeing those large vessels, it really is a good point that if there's a possibility that some of this uterine bleeding was vasculitic too. So people want to know. People want to know what the ANCA was. So Pravir, we want to give us a little follow up on before we discuss the case. Just
Yeah, absolutely.
Should we
yeah.
guess? I'll say.
Yeah,
I'll
go
say
ahead.
it was,
Go ahead.
I'll say it was MPO, and I'll say it
Mhm.
was a very high titer MPO.
so before we do that, I mean, one of the possibilities here is that this is ANCA negative, like a polyarteritis nodosa, since the vessels are larger and may even have some uterine involvement. Now, polyarteritis nodosa is a large vessel, but can have a glomerulonephritis with it. Is there any takers on that the ANCA will be negative? Steve?
No, it's a good point. I think it's going to be ANCA positive. And this isn't really, I mean, these are medium-sized vessels now. I mean, as far as I know, I mean, I don't know if there's beating of the renal arteries, the main renal arteries, but these are, as opposed to PAN, these are medium-sized vessels.
They are, but they're much bigger than as you pointed. We both pointed out. It's very
Exactly.
untypical.
No,
so,
I did, again, they usually don't coexist. It's usually all small vessel, and to have these medium size is kind of unusual. But I still think it's going to be ANCA positive. But
KC, ANCA positive, ANCA negative, MPO, PR3. What is it? High titer, low titer? You tell us.
I think ANCA positive, high titer.
MPO or PR3?
I'm going to go with PR3, bad vasculitis.
Okay.
GPA.
Revere.
So pending labs, SPEP, UPEP did not show any monoclonality. The ANCA was positive, and it was MPO with a very high titer of 137, 200. For what it's worth, we got an anti-histone antibody that was negative. But usually with any type of drug induced, I know that was brought up, those MPOs are really off the charts, but it was still pretty high. So MPO positive, PR3 was negative, so it wasn't a dual positive. Anti-GBM was checked. Of course, we don't see on the biopsy, but serology was negative. So I guess the next question.
Before you do that, if you give me 1 second, and there's in the chat says, does PAN usually spare pulmonary vessels? It's a good question. I mean, typically I think of polyarteritis nodosa with abdominal and microaneurysms and diagnosed by that. It's a little hard for me to say, so I don't know the answer to that. So, Pravir?
So we did, as people had been concerned about, we did start empiric steroids before the biopsy. I think given it was hard to tease, but with that creatinine, with the history, we started empiric steroids before the biopsy. And then we got the MPO titer back. And the question now is, what do you do? Let's start off with plasmapheresis. Would anyone start plasmapheresis? And we have a poll, and I think we can hear from our faculty, but I'll launch the poll here. Would you start plasmapheresis? Yes or no?
So a question that goes along with this, with these infiltrates that she had on chest X-ray, did you ever get a DLCO or anything to prove whether or not she had pulmonary hemorrhage? Because that might influence someone's decision on this as well.
Get a CT, didn't show anything that would concerning for diffuse alveolar hemorrhage.
Fair enough.
Her hemoglobin was stable, which I know is not a good marker. These patients.
No, but a thin section CT can pick it up. That's a good point.
We'll let this run a second, and then I want to put a couple faculty on the spot here, not in a bad way, but
pretty good here.
Yeah, pretty good and pretty interesting.
Yeah.
I think that'll swinging the other way. Hold on.
Okay, more interesting.
Yes, it's kind of swinging the other way.
There. How about we'll stop it right there. So
okay, good time to stop it. So it's pretty close, but 57% said yes, 43% said no. Well, let me just ask Dr. Rubin what he would do, and I'm going to ask somebody, whatever side he's taking, I'm going to ask somebody to defend the other side. So, Mario, would you flex this patient or not?
No.
And why not?
Just because I don't think in the absence of pulmonary hemorrhage that the evidence is there, not yet.
So what about this patient's had 2 months of pneumonia? How do you know this isn't pulmonary vasculitis all along?
Well, I mean, I thought her pulmonary picture did improve, didn't it, on its own? I mean,
Yeah, it did. It
without
did.
it? Yeah,
Yeah.
which will make a vasculitic etiology less likely. She was already infected. And you know me, I think that pheresis is not such an innocuous procedure. And, you know, from discussions offline with Dr. Glassok, I mean, we are aware that there have been reports of increased infectious complications in pheresis-treated patients.
So for those not privy to that, you know, after last week, we talked about last week's case was a case of cast nephropathy and the role of plasmapheresis for that. Not only would it work, but also is it a benign therapy? And after the conference, there was a lot back and forth between this group as to whether or not it was a pretty benign procedure or not. I made the point that in the collaborative study group trial, we went back and looked. That was the lupus nephritis trial in which we had Cytoxan and prednisone versus Cytoxan and prednisone and plasmapheresis, and we found that there was no increased infection in the plasmapheresis subgroup that received it. On the other hand, that went back and forth a little bit more, and there was a recent meta-analysis that did show that at least in other diseases where it's used, I think it was mostly vasculitis, that there was an increased risk of infection. So it hasn't been as welcomed as a benign procedure. And I think that's what a lot of Dr. Rubin's point is. I mean, he actually found the paper for us, that the meta-analysis, which might have shut me up at least. So you wouldn't do it. Let me ask our plasmapheresis guru at Rush, Dr. Gashti. Casey, argue the other side.
The other side argument would be, yes, I don't know if this pulmonary stuff is. Let me go back. I would actually do it, so I don't have to like sort of make it up, but I would do it because this patient's really, really. I mean, this is a pretty bad renal failure. The biopsy looks terrible. Although you could argue, based on the histology, this kidney is gone. So is this even worth doing anything at all? So that's.
But I think you did say that it was only 20% IFTA in the first slide. I mean, I know there's glomerular destruction, but I didn't hear the final numbers on the glomeruli.
Right. Yeah, I guess we never heard that. So, but it just looking at everything, it just looked so beat up that I wasn't sure if.
Yeah, so there were 18 gloms and 11 had necrotizing lesions, so 60%, and then none were globally sclerosed.
Okay, so then, so I'll take that. I stand corrected. So yeah, I would treat eventually, but the plasmapheresis part. I mean, there are studies that support. You know, it's been going on in the chat. Pexivast said don't do it; it doesn't help. MePEX said, you know, there was some signal that it would help. I tend to do it in patients with alveolar hemorrhage, and if they're dialysis dependent, I still kind of go back to the MePEX trial and I do it. So in this case, I would actually do it. Especially with high titers of ANCA, there is actually something you're removing. So whether ANCA is pathogenic, whether you believe that it is a directly pathogenic autoantibody, and removal of that by the time your immunosuppression kicks in is going to do you some good for that time period. If that's the argument, I would do it. I don't know about the risk of infection being that high to sort of balance out all the other benefits at this point. I think my argument is, what do you have to lose if you think infection risk is pretty low?
Yeah, well, that is the issue, and people don't think it's as low as I know that you and I do, but that doesn't mean we're right by any means. Pravir, MePEX, Pexivast keeps throwing up. Well,
Yeah, and that's why I'm glad that brought up, because I had these quickly, depending on time. Especially for the fellows, we keep on talking about, you know, these cutoffs and MePEX and Pexivast. Just in brief, you know, what the MePEX is, you know, here's a nice visual abstract on it, but I just wanted to make note of these patients with that cutoff where you see in the old KDIGO, and sometimes you'll hear about, is because it was a different unit. So you're using greater than 500. We're used to our milligrams per deciliter, but not everyone uses that. So that's where that cutoff of 5.7, 5.8 comes from. And these are the patients that were studied, and in these patients had pretty severe disease. And the only thing, you know, to remember with the MEPEX trial was they excluded patients who had alveolar hemorrhage. So here you did see that there was decreased kidney failure at 12 months, but there was no survival benefit. Oops. And they actually had a long-term follow-up, and at about 4 years follow-up, the risk of death and end-stage kidney disease was very similar between the two groups. So people argue that one, you know, being off dialysis for a year is a big deal, which it is, and that's part of it. So this was what we used to use, and it was a cutoff. People who are either dialysis dependent or the creatinine was greater than 5.8, those patients would get started on plasmapheresis. Now, more recently, especially for you may have heard about the Pexavas. Now, the only things to note here was the creatinine mean was about 3.7. They did include patients who had diffuse alveolar hemorrhage, but there's only 30% of them had it. So 70% of patients did not have diffuse alveolar hemorrhage. It was about 59% MPO and 40%, the rest were PR3. And their GFRs were less than 50. So here there was no signal. Again, we're not going to go into the steroid part, but there was no improvement. Now, if you look at the subgroup analysis, those that had what they call severe DAH, the hazard ratio was down to 0.64, but was not statistical significant. So one of the things has been is that was it powered enough, even though it had more patients than the MEPEX trial. But this has really change the general theme, and we can hear that today, is that we wouldn't do plasmapheresis right away. So I just wanted to quickly, because those came up in the chat, so I'm glad I had the abstracts on that.
The other thing to keep in mind, and you alluded to this, and in the MEPEX trial, those patients all had acute renal failure. I mean, anybody that had any kind of chronic disease was not included. And as you say, their creatinine had to be essentially in milligram per deciliter 5.8. But those patients were all biopsied, if I recall.
Yeah, and the Pexavas biopsies were not required, so we don't have biopsies on these patients on the Pexavas.
The only other thing was that early on, a larger proportion of patients pheresed actually came off dialysis. In the long-term follow-up, and I thought they had 10-year follow-up. Ultimately, it was a wash as far as death or end-stage renal disease. But early on, a larger portion did come off that had gotten pheresed in the MEPEX trial.
Yeah, and that's what the whole thing is, that they had better kidney, survival. Kidney off dialysis in the first at 12 months, but overall the mortality, there was no survival benefit in the long run. But yes, in the long-term follow-up after 4 or 5 years, it was kind of a wash in terms of dialysis and overall patient survival. So
I think what the Pexavas trial didn't answer, and this is well known, is obviously if you have concomitant GBM disease, which our patient didn't have, that's an indication to still do Plex. If it's severe alveolar hemorrhage, where they're either intubated or their anemia is so severe from the alveolar hemorrhage, then there weren't enough of the severe alveolar hemorrhage in the Pexavas to do it. But mild to moderate alveolar hemorrhage was not an indication if it's ANCA alone.
Yeah, and both of these trials excluded patients who had anti-GBM. So those dual positive patients were not included in these studies. So I guess the next part is okay, fine, we may not agree on Plex. How would you go ahead and treat this patient? We have a third poll of options, and these are the options that we have listed here. Would you do cyclophosphamide plus steroids, whatever your preference is on plasmapheresis, rituximab plus steroids plus minus plasmapheresis, or rituximab plus low dose cyclophosphamide plus steroids with plasmapheresis at your, I guess, discretion, or something other? And that's why we have the other option. You can put it in the chat. So a few more seconds here and we can get all right. So I can share the results here.
It's pretty well spread out between the three of those, except for other. I think people are wondering about C5a inhibitors, but not really in the acute armamentarium yet. In 2 words, Mario, what would you do? Which of these?
Well, the more and more I read about this, the more and more I like C, which is the John Niles Mass General approach. The
Casey?
combination of Rituxan, cyclophosphamide, and steroids.
I agree with Dr. Rubin. C is the Rituximab trial.
Bill?
I haven't, I think any of the top three are good choices, but I would, in this case, I would do Rituxan plus steroids alone.
So, Pravir, what you want to tell us about some of these options here?
Yeah, so of course, cyclophosphamide plus steroids versus rituximab for steroids are the ones that we generally more hear about. Actually, the one that has been around but has gained a little more attention is that choice C. And sure enough, it has been studied. These are not randomized controlled trials, and again, not to be going to the depth, but it has been shown and studied using both combination therapy with rituximab and cyclophosphamide. And this was the Niles paper, and these patients were 70% MPO. They had a median time to complete remission. It was 4 months, and by 5 months, 84% of the patients were in complete remission, which is really good. And the rate of some of these patients did get plex, not all of them. It wasn't the thing they were studied, but the rate of serious infections in patients who did receive plex here was similar to that what we saw in the RAVE trial, which, again, with rituximab in the prior older studies. So, they did cyclophosphamide, and they did a pretty, fast prednisone taper, and they got rituximab 1 gram, 2 weeks apart, and then every 4 months they were checking B cell levels. So this is an option. And the thing here is that hopefully you can also reduce the prednisone, which is always something that everyone is interested in. And there's also been a recent study, which I didn't know of until I started putting this together, of using both of those combination therapies plus plasmapheresis. Now this is by Galati and Edwards, and this is a visual abstract, but there's 64. Again, these are not randomized controlled trials. Most of these are observational, and you have to kind of take that with your kind of overall understanding of how this works. But these patients were sick, though. That's what I took out of this. These patients were really sick. Their creatinines, again, this would be above 5.8. Their 47% were dialysis dependent. These did have diffuse alveolar hemorrhage. And so these vasculitis, they're pretty bad, severe vasculitis, and they got plasmapheresis, cyclophosphamide, Rituxan, and oral prednisone. And they had really good response rates. 67% of patients recovered from dialysis dependent renal failure. And you can see, of course, those that were on RT at time of presentation, of course, had worse than those who weren't on RT, but still there was some ESKD-free survival. So this combination therapy, which to me seems, big, a lot of immunosuppression, it does work. And overall, what we want to know is the infection and the serious adverse effects. From what I could gather from these studies, there was nothing more than they would expect from just doing rituximab or cyclophosphamide alone with steroids. So the infection rates were not higher with these, although in the plex, there's been some plex data which we don't go into, but that's a whole different discussion.
Pravir, in the text, it says cyclophosphamide PO. It was oral in most of these studies, correct?
Yes, this was oral. Yep.
Yeah.
This was, and they did 2 to 2.5 milligrams per deciliter PO. They reduced it for, of course, a lot of these patients were dialysis dependent, so they had to reduce it for EGFR or renal failure.
I'll skip the other chat comments. You can read them because I think that you have some more to present here.
Yeah, and so this is what we did. What did I do with our patient coming back? I think I will say we have a lot of follow-up. So this, the thing I didn't say in the beginning was this is pre-COVID, pre-Pexavas, which seems like years and years ago. And so what we did is I did steroids. We did start empiric steroids before. I did PO Cytoxan. We did do plasmapheresis for this patient. Again, this is well before Pexavas. And again, we looked at the patient, pretty sick, and we wanted to give the patient a shot. Patient became dialysis dependent here, and so that's why the creatinine came down. But you can see about 60 days after presentation, this patient was still requiring dialysis. And about 3 months after of high dose Cytoxan, prednisone, and completing plasmapheresis in the hospital, the patient remained dialysis dependent. So at this point, I made the decision to stop the cyclophosphamide after 3 months. She was making some urine, but not enough to see significant clearance, and I tapered off her steroids. And over the course of, now coming up to 6-7 months after her presentation, her creatinine was still around 5. And these are all, pre-dialysis creatinines. And so this is the MPO titers I did follow. On presentation, like I said, it was severely elevated. That came down to really undetectable, even 6 months out. I did check ESR-CRPs. Unfortunately, I didn't have an ESR when she came in, but the rest were much improved and stable. So my question then became, what do I do here? The cyclophosphamide I stopped. She remained dialysis dependent after 3 months, and now it's 6 months, and she's still dialysis dependent. Her MPO is negative. She's off all immunosuppression. What do you do here? Is there anything further to do? Do you maintenance therapy if she's still dialysis dependent? Do I go searching for other vasculitis, manifestations? She, for all purposes, had no rash, was active, going to work, and had no respiratory complaints. So I don't know if anyone has any other thoughts. Otherwise, I'll keep moving on. If what they would they do immunosuppression again? Or do anything different?
Well, my feeling is that these diseases have a tendency to come back, and I'm not, while I may not use maintenance therapy forever, I don't like to just quit after the first round of induction. Certainly with PR3, I'd keep it on a long time. With MPO or vasculitis, I don't feel as strongly. That the kicker here is she's on dialysis, and there's a lot of been written about dialysis itself being immunosuppressive and the decreased risk of relapse just from your immunosuppression related to renal failure. I'm not sure. I probably would have given her at least one more dose. She was very sick. She had probably pulmonary involvement in addition to everything else, maybe even uterine involvement, as has been suggested. So I probably would have, even though she's doing fine, and the ANCA is now negative. Although there's obviously, I think you've got a good marker on her, so you could probably just follow markers. Anybody feel differently, strongly, that she shouldn't be?
I do. I think that what I would like to do is biopsy her again to evaluate the degree of chronicity at this point. She's been on dialysis for quite a while, and the process goes on. So before I institute any additional immunosuppression in a patient who has been dialysis dependent, I am curious to know the extent of chronicity.
And so that would determine your therapy?
That will depend. That will determine whether I add maintenance immunosuppression or just let it ride.
See, the way I look at it, it's a really good point. It didn't even occur to me to rebiopsy her, but the way I look at it is independent of her renal disease, she's got, systemic disease. So whether or not I'm going to treat her, even if she's got a dead kidney, I might still consider giving her maintenance for a while because she was so systemically ill.
But she has no signs of extrarenal disease at this point, does she?
Yeah, that's valid. That's very valid. She doesn't, but when it comes
What
to
about the uterine
She's 7
fibroid
months
bleeding?
out, right?
Yeah, she's 7 months. This is 6-7 months out.
Casey, I'm sorry.
I thought we were talking about how her uterine bleeding and all that stuff was vasculitis.
Did it, what happened with that, Pravir? Did she have a hysterectomy or
She did not, and it did resolve.
it resolved? Interesting.
With immunosuppressive treatment or with what?
It's she with immunosuppressive treatment, it did resolve. She never had going and getting her hysterectomy. Her vaginal bleeding did not come back. She had the fibroids, which if it gives her pain, but overall her bleeding stopped.
So I guess the decision is really based on if you think there's extrarenal vasculitis or not. If she's on dialysis and you're giving up on her kidneys, then it doesn't make sense to continue immunosuppression. But if there's extrarenal stuff, then it makes sense to continue.
So tell us what you did.
Yeah, that's exactly what. So I ended up getting a survey. I just got a CT chest, and she had she had some what they basically thought was some interstitial disease, and I thought this was just prior from her pneumonia was probably just systemic involvement with her vasculitis, and they didn't think that she needed immunosuppression from that point. While this is going on, and you can kind of see here, this is right here, her creatinine starts to come down, and she tells me that she's making more urine. So as she's getting CT, seeing the rheumatologist, I send her over to the pulmonologist. she starts telling me, hey, I'm making a lot more urine. So sure enough, we checked another creatinine. This is pre-dialysis, is down to 2. And then I did a 24-hour urine creatinine clearance, and it was greater than, it was greater than 20, 25. And so we decided to see what would happen when she came off dialysis. And now we are, sure enough, 3 years later, and she's been off dialysis for this long. And her creatinine, this is just from a couple months ago, was 1.7. I never redosed her. I got pulmonary, did not think that, this was all interstitial scarring, did not think she needed further immunosuppression. Her urine bleeding never reoccurred. She never got a hysterectomy. I maxed her out on an ARB, which controlled her blood pressure. And these are her follow-up labs 3 years later. Her MPO has remained negative. Her ESRC-CRP I continue to follow. And because like everyone said, I'm still worried that there's going to be a flare-up. And at that point, I think, as Dr. Rubin said, I think a biopsy would be definitely the next step. And so I've been watching her urinalyses, and sure enough, her UAs have had, no more blood. Her UPC ratio was down to 0.2 this year. And she's been off dialysis now for almost 2.5 years, which was just remarkable. And, fortunately, we haven't had to do anything really.
Yeah, well, it's hard to argue to do that now. And clearly, had I done it, I'd say, look how well she's doing, because I gave her rituximab as maintenance. But obviously, your control shows me that she didn't need it. And, maybe as it was pointed out, in case you just put in the text box, that the dialysis was treating her all along, and maybe it's her CKD2 degree. It also means that, MP, microscopic polyangiitis, doesn't always relapse by any means, whereas,
PR3.
GPA is a much higher risk of relapse. And perhaps I overtreat these patients because they don't always relapse. But what an amazing outcome. I mean, if you would have told me this woman came off dialysis, I mean, I know this is possible, but that's a really far out. And it's not prolonged ATN. This is bad crescentic GN with dialysis dependence that 7 or 9 months later finally comes off dialysis. That's very remarkable. And she's very lucky to have done so well. I was glad to hear Mario say that he would use triple therapy. Now, I know that I don't think that study will ever be done comparing, double therapy to triple therapy, but I really like the idea behind it. This is about as bad as you can get. I think one of the reasons, when I mean double, the triple is the plex, the double is the low dose cyclophosphamide with the rituximab. I think one of the rationales for that whole thing was to get down on the steroids and use less steroids, which that is the big movement now. But regardless, to think that years ago we would give both of them, I don't think anybody would have ever thought about that. I certainly wouldn't have thought about giving them together. I think it's one or the other, but I think these are people that are smart and thinking outside the box, and I don't know that they'll ever be tested, but I think the success speaks pretty well for itself. And but even then, this was 3 years ago, and she got single therapy, and she did amazingly well. I think that there's a lot of lessons here. Pravir, do you think that this pulmonary disease was her vasculitis?
I think so. I think it just got treated because I treated her basically systemically aggressively. And I think that's the scarring that we're seeing on the repeat CT. I think the pneumonia was the first, and then just kind of took off. It's interesting enough. I don't know why she didn't have DH. I mean, she never got bronch, so we never knew, but the CT didn't show it. But I think it had to be all related.
And has anybody ever heard of uterine? I mean, it may be common. I don't know, uterine vasculitis.
I'm sure.
I suppose there's no reason why not. I'm sorry.
I'm sure it's in the literature. I mean, we can search it after the conference. I'm sure it's there.
And if it's a case, it's going to be one that also has medium-sized, arteritis. I bet. Those would be the ones that you'd really see any other organs, I would think.
I mean, people used to talk about looking back at cholecystectomies and people that they thought had cholecystitis and finding vasculitis, as a kind of a poor man's way of backing into the diagnosis. So who knows? I mean, I assume any vessel could be involved. Just as an aside, there was a New England Journal article not too long ago, but this was a PR3 vasculitis. And in addition to rituximab, cyclophosphamide, and steroids, they actually gave eculizumab as well. And they came up with a rationale as to why they did that, which I thought was kind of interesting.
Yeah, I've seen reports of eculizumab being used for almost everything now, and they're often done because it's refractory. It's not, and since it's refractory to everything else, maybe the patient serves as their own control. It's hardly randomized and accepted, but it's really interesting, and we're appreciating the role of complement in many of these things, even when it's paucity immune. I'm going to wrap this up. This is a really, really great case. There's a lot of lessons here. I think excuse me, I'm going to botch your name, but Dr. Panasamy gets the Occam Award today for predicting the uterine disease. I like that diagnosis, and I'm sticking with it because it puts it all together and maybe explains why everything improved. Casey, thank you. Bill, thank you. Dr. Rubin, thank you. Pravir, especially, wonderful case. Bill, great discussion. We'll be back next week for another great case. So everybody stay safe.